To illustrate why you will see 5 spine surgeons that get 5 different opinions, I'm going to talk about a degenerative spondylolisthesis, which is an instability in the bones which can cause stenosis. So surgeon A will recommend an open anterior fusion with an anterior incision and an open posterior decompression and fusion. That is the most invasive way of dealing with this problem. Surgeon B will recommend a lateral fusion where a 2-inch incision is made on the side, the spacer is put in from the side, and then an open posterior decompression and fusion. Now they also may recommend percutaneous screws, and that's surgeon preference and also dependent on the pathology. Surgeon C will recommend 1 incision on the back, which is an open TLIF or posterior lumbar fusion, where they do the decompression and put the screws in. You can see the spacer is smaller, so there's a slightly lower fusion rate for this because there is a smaller spacer. Surgeon D, such as myself, generally would recommend a 2-incision minimally invasive lumbar fusion where the whole surgery is done through a 22mm tube on an outpatient basis to decompress the nerves and fuse them. Now, the surgery is the same for an open TLIF versus an MIS TLIF in terms of the spine. It's just the collateral damage is less. Surgeon E will recommend an endoscopic decompression where the stenosis, the pinching of the nerves, is relieved, but the instability is not addressed. And that may be good for somebody who's just having hip and leg pain and they're not really having much pain from the spondylolisthesis and it doesn't move on flexion extension. And what I want to point out to you about all 5 of these options is none of them are outright wrong. They all have value and they may be the right choice for specific patients. Things that need to be considered are age of the patient, comorbidities, stage of life, what kind of recovery the patient wants. The first way, the full open anterior posterior way, is not wrong. It's just the most invasive way of doing it. But in somebody who's obese and diabetic, you may need that level of surgery to ensure that you get a fusion. Generally, in my practice, I'll do a 2-incision minimally invasive lumbar fusion, and the fusion rate is greater than 95%, and patients do very well and has a shorter recovery time. The endoscopic decompression way is not wrong, but we don't know the rate of progression of spondylolisthesis after an endoscopic decompression, and that patient may need a fusion later. If you have a 60-year-old patient who is having pain from the stenosis and he just wants that relief but wants to return to work quickly, and then maybe when he's 65 or 70, then he needs a fusion, that's the choice for him. All of these techniques will yield a good result if they're done well and the patient heals properly, but the recovery times will be different. The risk for any adjacent segment problem will be different. So I know it's very confusing, but you have to talk to your surgeon. Your surgeon should lay out your options for you, and your surgeon and yourself should have a discussion as to what the best choice is for you. There is no one size fits all for every spine surgery.